This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Neurocritical Care, published in 2026, titled Invasive and Non-Invasive Intracranial Pressure Pulse Waveform in Neurocritical Care Patients with Different Cranium Integrity.
This is a paper that really hits home for those of us in the ICU. We've all spent hours staring at intracranial pressure monitors, trying to decipher the meaning behind the waves, beyond just the mean ICP number. But this study, led by Magdalena Kasprowicz and a multi-center team, takes it a step further by using artificial intelligence and non-invasive sensors.
Exactly. Before we dive into the data, we should probably set the stage for our residents and students. When we talk about the ICP pulse waveform, we're looking at the dynamic interplay between arterial blood inflow, venous outflow, and the craniospinal pressure volume compensatory mechanisms.
Right. Classically, we teach the three peaks: P1, the percussion wave; P2, the tidal wave; and P3, the dicrotic wave. In a healthy brain with good compliance, P1 is the highest. But when compensatory reserve is exhausted, say from cerebral edema or a large hemorrhage, P2 begins to rise and may even exceed P1.
And that's the clinical challenge, isn't it? Manually identifying these peaks is notoriously difficult. The paper notes that peak configuration varies wildly between patients and even over time in the same patient. Sometimes in pathological states, the waveform becomes a single triangular or sinusoid-like peak, and you can't even find a distinct P2 to measure.
Which is why this concept of the Pulse Shape Index, or PSI, is so interesting. It's an AI-supported parameter that classifies these waveforms automatically. Alara, walk us through how they actually calculated this PSI in the study.
So the researchers used a neural network to classify pulse waveforms into 4 categories. Class 1 is a normal waveform, while Class 4 is highly pathological. The PSI itself is the weighted average of these class numbers. Essentially, it allows for real-time automated tracking of morphology without the need for a human to manually peak the P1 or P2.
And the big question they were asking was, can we get this same morphological data non-invasively? They compared standard invasive ICP monitoring, what we'll call PSI ICP, with a non-invasive sensor called Brain4Care, or B4C.
The B4C is an interesting piece of tech. It's a non-invasive sensor that detects small cranial bone deformations, micrometers really, that occur due to ICP fluctuations. The study included 47 adult patients with a median age of 43, but what made the study unique was how they grouped these patients based on their cranial integrity.
That's a critical variable in neurosurgery. They had 3 groups: 17 patients with an intact skull, 17 with large skull fractures or craniotomies, and 13 who had undergone a decompressive craniectomy.
They also performed in jugular vein, or IGV, compression to see how a sudden slight increase in ICP would affect the waveform morphology.
So, let's get to the results. How did the non-invasive B4C stack up against our gold standard invasive monitors?
Surprisingly well. The Bland-Altman analysis showed good agreement between the invasive PSI and the non-invasive PSI. Only about 6% of the data points were outliers. This suggests that the B4C signal is indeed capable of reflecting the ICP waveform morphology non-invasively.
That's a huge win for non-invasive monitoring. But I think the most provocative finding in this paper relates to the craniectomy group. If you look at the PSI values, there's a significant difference depending on the state of the skull.
Yes, this was a standout result. Patients who had a craniectomy had significantly higher, meaning more pathological, PSI values compared to those with intact skulls or even those with craniotomies. Specifically, the median PSI ICP for craniectomy patients was 3.5, whereas it was only 2.0 for those with intact skulls.
Now, let's pause there for a second for our residents. On the surface, you might think, wait, we do a craniectomy to improve compliance and lower pressure. Why would the waveform look more pathological?
The authors address this. They suggest that after a craniectomy, the closed box of the Monroe-Kelly doctrine is gone. The brain is no longer encased in a rigid container, so the pressure-volume relationship is completely altered. The pulse waveform might become more sinusoidal or dominant in a single peak, not because the brain is dying, but because the physical environment of the cranium has changed so drastically.
It's a reminder that we can't interpret these waveforms in a vacuum. A PSI of 3.5 in an intact skull might mean imminent herniation, but in a craniectomy patient, it reflects a different biomechanical reality.
Another interesting point was the IGV compression. You'd think that by compressing the jugulars and causing venous congestion, the PSI would spike, but the study found that IGV compression did not significantly affect the PSI.
Why do you think that is, Ilara?
The paper suggests that while IGV compression causes a sudden, slight change in the mean ICP, it doesn't necessarily shift the underlying compensatory reserve enough to change the pulse shape itself, at least not in the short term. The PSI seems to be a more stable marker of the overall state of the system rather than a reflection of transient pressure fluctuations.
That adds a layer of reliability to the PSI. It's not noisy in the face of minor physiological shifts. Now, what about age? I saw there was a correlation there.
Right. Both the invasive and non-invasive PSI correlated with age. The Spearlin correlation was about 0.35 for invasive and 0.37 for non-invasive. Essentially, as patients get older, their PSI tends to be higher. This aligns with what we know about aging, reduced brain volume, and changes in cerebrovascular compliance.
So if I'm a resident on call and I'm looking at this B4C monitor, I need to keep in mind the patient's age and whether they have a bone flap in or out.
Exactly. The study really highlights that PSI is a promising monitoring alternative, but it's influenced by these specific factors.
Let's talk about the AI classification for a moment. The paper mentions that the neural network was trained to look at the pulse morphology and categorize it from 1 to 4. In pathological cases, it mentions a triangular or sinusoid-like shape. For our listeners who are more visual, this is when P2 and P3 essentially merge into the downslope of P1, or P2 becomes the dominant peak.
And the automation is the key. In the past, researchers used the P2 to P1 ratio, but that requires you to actually find P1 and P2. If the wave is just a single mount, the ratio is mathematically impossible to calculate. The PSI bypasses that by looking at the whole shape.
Which is why the paper mentions the multitude of morphological parameters can complicate clinical interpretation. The PSI simplifies it into a single number, arbitrary units, that a nurse or a resident can track over time.
It's also worth noting the study's limitations, as specified by the authors. This was a relatively small sample, 47 patients, and while the agreement was good, we are still in the early days of using these non-invasive indices to guide actual surgical intervention.
True, but the good agreement found in the Bland-Altman analysis, with those 6% outliers, is quite encouraging for the B4C system. In neurocritical care, we're always looking for ways to reduce the risks associated with invasive monitors, like hemorrhage or infection. If we can get reliable waveform data from a sensor that just sits on the scalp, that's a massive leap forward.
To summarize the key takeaways for our listeners, 1. The Pulse Shape Index, or PSI, calculated from non-invasive B4C sensors, shows strong agreement with invasive ICP recordings. 2. The PSI is significantly higher in patients with craniectomies, which likely reflects the altered biomechanics of an open skull. 3. Age is a factor. Older patients have higher PSI. And 4. The PSI is stable during brief venous outflow obstructions like IGV compression.
This paper by Kasprowicz and colleagues really moves the needle on non-invasive neuromonitoring. It's not just about the number anymore, it's about the shape. And it seems the future of neurocritical care might be shaped by AI.
It's a great study. For those interested, the full details on the neural network classification and the Bland-Altman plots are in the 2026 issue of Neurocritical Care.
Well, that's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Ilara. We'll see you next time.